I'll just follow Hassan. Great talk with more about outcomes, specific outcome in athletes. So Damien talked about hip scope in athletes. I'll talk more about the outcomes. So we all have success stories, different sports. So we know that hip arthroscopy in elite athletes works, and there's a lot of literature that's been published. We have Mario Bizzini here. There's a bunch of articles that we can see here that's been published. So we have evidence from expert surgeons or therapists that hip scope in athletes has worked. But how do we define the elite athlete? I've seen a lot of articles talking about high school kids, college kids. But really, if you look at a world-class performer, we know that 0.03% of high school players go professional, and 0.9% of college players go professional. So our definition in this talk of elite athlete is an Olympic athlete, any athlete playing for an organized professional team, or any athlete for whom competing in a sport is their primary job or source of income. So I think we have to be careful of what we're reading and how we define these athletes. So this is in America, baseball player. I don't want to compare it to cricket, but basically there's a forceful torque, especially these home run hitters. So this is with force plate analysis. We can see that his back leg and his front leg are subjected to significant force. And this is an athlete who was one of the best in the Major League Baseball, so a lot of torque on his hip. When I was in Pittsburgh, we looked at force in the anterior posterior plane, rotational plane, and we found that baseball, football, golf all generate significant force both in the AP plane and side-to-side plane. And again, same thing with rotation. We talked about earlier about the short rotators being important. I think they're very important, especially in patients with annoying impingement, chronic problem. The short rotators get short, tight, and that affects their performance. This is a patient, figure skater. I never thought about I would give a talk about winter sport in Qatar, but these kind of athletes are important in North America and Europe, and they create a lot of torque on their hip. This is a patient skier is coming down the hill, and everybody was focused on his knee. He unfortunately hooked a gate, and this is a bad injury. So he had a bad knee problem and a bad hip problem. So these kind of traumatic injuries in these elite athletes can be challenging because you have to look at the whole axis, and the post-kinetic chain of these athletes' muscle is totally shut down after these injuries. But this kid recovered, and we got him back on track. This is a ice hockey player, butterfly style. Patrick was a pretty well-known Hall of Famer hockey player in North America. He developed that style. So the butterfly style is probably the worst range of motion in a ice hockey player because they go in flexion, adduction, and rotation, and they really stress the controllable junction, especially with underlying impingement. This is just a simple tennis player. What's interesting in this dynamic view here is that if you look on the right side was his symptomatic hip, and as he was going down, I would think he would protect his right side, but what he was doing, he was actually compressing his right side harder because he wanted to have his convexity at the head neck junction fits in the acetabulum. So it was actually showing more force on the right side than the left side. This is a paper of McMaster with Feeney here, and basically we look at return to pre-injury activity level after surgical management of FAI in athletes. And in that study, the study that were included in the study were required to have a minimum of 6 months follow-up, exclusive FAI treatment in a patient population of athletes. So only 9 articles met the criteria. So there was 418 athletes, and of the whole cohort, 92% returned to sport, and 88% returned to pre-injury activity levels. So there was 2 groups, the rec athletes and the pro athletes. It's interesting to find out that the rec athlete didn't return to sport at the same level as the pro athletes. And it makes sense if you look at the underlying muscular structure. Most pro and Olympic athletes have better underlying muscular structure. So for us to return them to sport, especially in the definition we said earlier about the elite athlete, we have to make sure they pass a hip sports test that's based off Dr. Stedman knee sports test that he designed way back when he was in Lake Tahoe. We use the same sports test for the hip. We don't want to have greater than 20% muscle imbalance. That's between the agonist and antagonist and the flexor extensors and rotators and abductors as well. And we want to have a normal gait. This is actually the sports test. The videos are not working here, but basically we have them do endurance, side-to-side agility, and also single leg knee bends. And we also crisscross the step as well. So we really want to look at their proprioception, their agility before we turn them to play. Also, we talk about rehab extensively here, but we like to do functional rehab. Once they reach 5-6 weeks, we put them on a functional rehab program. This is actually an NFL kicker on the left, and on the right, this is just a basketball player. So right away, as soon as we feel they're stable enough, we geared our rehab toward the functional sport that they're good at. And I think muscle memory plays a very important role in the recovery of this patient. So this is an old paper published in 2007. Again, Damien was mentioning most of us have publication about athletes. These were a cohort early on of pro athletes. We just look at 112 pro athletes that we treated, and we come down with 45 of those who required truly FAI treatment. The average age was 31. And in that cohort, we had a group of patients, a cohort who had previous surgery. It was 24%. So the average time to follow-up was 1.6 years. And all these patients had labral tears, almost 50% had grade 4 acetabular defect. I'm thinking about Dr. Sadri's talk earlier. It's a pretty large, and grade 4, it's down to bone. So it's a very difficult group of patients. And 7% had grade 4 in the head, and 7% had diffuse OA. So we returned 93% to pro play. 3 of them did not return because, and they were playing football, American football, baseball, and hockey. And those patients had diffuse change at the time of surgery. That's back in 2007. Back then, we were scoping more patients than we are today, but we know now that diffuse changes don't necessarily lead to good outcome, and most of them would qualify for surgery today in our hands. This is actually a paper that was focusing on NHL hockey players. So these are all elite. NHL arguably is probably one of the best league in the world for ice hockey, so a lot of the men on these patients. So we were able to follow all these patients extensively. The post-op IRSIP score was very high, 95, from 70 to 95, and the patient satisfaction was also very high. Now, if we look at the same group of patients with microfracture, so these were also all pro athletes, and I was just curious to answer that question. These pro athletes because it's a question they always ask to us, can we return to play the same level with that procedure? So we look at this groups here. We had 39 patients with microfracture, and the control was without the microfracture. All baseline FAI treatment in our hands, single surgeon. So basically, statistically, there was no difference. If we treat the condyle defect with microfracture or no microfracture, these patients return to the same level of play at the same rate. So in our hands, specifically for the hip joint, we feel that if we have to treat this condyle defect, we can return them. We give them the same stats as far as return to play. And I think it's important because, like Hassan was showing, sometimes you have these 20-year-old hockey players with large condyle defect, and they want to know how the career is going to be subsequent to the treatment. So I think this paper helps us answer these questions. Now, we saw Damien talking about labral reconstruction. This is a group of patients, again, all pro athletes, that require labral reconstruction. So we had 21 males and different sports: soccer, ice hockey, American football, skiing, baseball, basketball, and ice skating. And in that cohort of patients, we had 2 that we had to convert to arthroplasty. The mean follow-up was 32.3 months, and we had over 80% detailed follow-up. So these are the scores we had on this patient, again with the labral reconstruction. So the modified high-risk, the HUS-ADL, the HUS-Sport, SFPCS, SFMCS, and the WOMAC all improved after the procedure. Then, if we look, this is a different cohort of patient. We look at the mean survivorship at 3 years, labral reconstruction. I just want to show that as a comparison. So again, the scores improve. We found that in pro athletes, the delta is almost the same as in non-pro athletes. Return to function, again, if we look at most of these athletes, baseline return to function pre-injury level is very high, upper of 80%, low 90%. But I think better in training this patient is to go for prevention. And I think a lot of these patients would benefit from pre-season screening to identify the hip at risk. A few years ago, we were asked by a college team in California to look at their football players who were dealing with a lot of hip injuries. So we put together a very simple screening program, and also we just modified their rehab program. Basically, we just decreased the amount of deep squats they were doing. Instead of going down to 90 or even higher, we're stopping them at 70 degrees. In season, like I said, we just modified a training program. Off season, we just monitor the pathology. If needed, we proceed with the surgical intervention. And in Vail, we have a lot of winter sport, so we deal a lot of ice hockey players and skiers. So we started a screening program, and basically we use Pee-wee and midget. Pee-wees are 12-year-old, and midget are more like 16-year-old. Symptomatic. We have clinical exam and MRI. 7 of the 17 Pee-wee and 15 and 18 midgets were observed to have acetabular tear on MRI. And the midget players were with positive clinical exam findings were 15 times more likely to have a high alpha angle, that meaning like greater than 64 degrees. So we compared ice hockey players, so it's different motion than the alpine skiers. So we found that ice hockey players had a higher alpha angle, and also the ice hockey player alpha was correlating with their age. And in hockey players, 75% of these kids had an alpha angle greater than 55, and the skiers it was 42%. So our hypothesis is that certain sports, certain motion at risk will lead to enhanced development of bony overgrowth at the head and neck junction. And we think that's because if you play a sport at a high level at an early age, it's just your physis, and you'll have a reactive callus formation. How we test for these patients, we like to use the Faber distance test in our hands. It's been working well, and also we, of course, look at the decrease in rotation. So that's the screening test we use. It's a very screening test we use in our athletes. So in college, the hip is the second most common site of injury. So we've put programs together. We look at the hip at risk. We modify their activity, the factor at risk. And then, again, we've had some success with modifying activity short term. It's a little bit like in the shoulder, the little picture, we have pitch counts. So we're trying to put together protocols, especially in ice hockey player at the age group at risk, where we can prevent this development of large alpha angle and maybe minimize at a later age the problem at the condylar junction. So in the future, we want to look at CAM lesion, and we feel that the CAM lesion will differ depending on their sport. Ice hockey players different than skiers, different than tennis player than a football player. We also look at pincer impingement. We know that the pelvic tilt, I was just talking earlier at the break about how the pelvic tilt will influence your subspinal impingement. So maybe we can modify that with a good protocol, physical therapy protocol. I think it's important to identify these young kids at risk because we can prevent these large condylar defects like Hassan was showing us. I mean, when you see a 16, 17-year-old with this large grade 4 lesion, that will have an impact on their career. And again, I think we have to get better diagnosing this patient early on and differentiate between extra-articular versus intra-articular problem. Minimize the steroid injections, and better rehab is very important. So in conclusion, it looks like in this group of patients, the really high-level elite athlete, FAI treatment is successful. FAI is very prevalent. The motion at risk varies per sport, and that will gear your treatment at the time of surgery, but your post-op rehab. And I think if you follow the correct algorithm, you can return these athletes to their sports. And functional rehab is certainly important in developing these treatment and improving our outcomes. Thank you very much.